Hi, I'm Kristin, go by Kiki as well. And I'm an infertility coach after going through IVF myself. I did 3 rounds in my effort to become a mother. And I had all 3 outcomes. I had one that didn't work, one that worked, and I had one that ended in a miscarriage. So I feel like that gives me a lot of perspective to be able to help other women who are still on the journey waiting to become mothers. And that's what I do now. And I am so glad that you guys are here. And I'm so glad to be able to share this information, because this is the kind of stuff that I wish I knew before even my first round, and it took like second round and third round, I was still learning. So I'm just really excited that you guys are here, and I feel like you're kind of ahead of the game. And so I'm also going to pass off to Dr. Likes, because he's going to take it away from here.
All right. Thanks, Kristin. So again, welcome. And we really do thank you for taking your time out of your Thursday night. I know everybody's busy. Hopefully this will be thought-provoking and something you learn. I do see a lot of familiar faces and names, and so I appreciate them being here. Some of the folks here may have already heard some of the things I'm going to say. I hope that's all right. And also, if they have, then maybe they can share their knowledge as well. So thank you for being here. For those who don't know me, again, my name is Creighton Likes. I'm born and raised in South Carolina. I did medical school down in Charleston, South Carolina, and then I did my residency in OBGYN here in Greenville, and then I did my fellowship in infertility at Duke, and I've been back here for, a decade now. So it's good to be back in South Carolina. Not that North Carolina is very far, but that's me. That's where my training was, and I've enjoyed what I've been doing for the last 10 years. So the other thing I'll say before we start is a couple things. Housekeeping. One, I am on call, so if I get called and paged and I have to duck out, that's why. 2, this is not meant to be medical advice to override if you have another plan from another physician, just so you know. This is, again, informative, and hopefully it will be informative for you for the IVF process. I say that because, as a lot of my patients know, this is very individualized medicine, and you'll see that as we go through, as my talk goes through. And so that's why I say that. I'm not saying this is a box that everybody fits in by any stretch. And so that's why I say, if you have another physician that's doing the fertility standpoint, I'm not trying to override them. There are many ways to do this. Speaking to that, many physicians have different ways of doing this, so there are different protocols. We'll hit on some of them. And so again, it's very individualized. So with that, I will start in terms of that IVF process. And a lot of our patients that come to us have done some sort of fertility, whether it be Femera or Clomid, with their general OBGYN. And because of that, excuse me, sometimes they've had a lot of the workup already completed. But once they come to us, there is a fairly extensive workup that we'll do once IVF has decided that's the best route for success. And what I mean by that is the preliminary stages of IVF are the evaluations. And so the evaluations are going to include lab work from both sides, actually, male and female. If it's the same-sex couple, obviously the donor sperm will have the infectious disease already done, but lab work from both sides. Definitely a uterine cavity evaluation, and there are multiple ways to do that. But I tell patients all the time, if we're doing IVF and we're going to transfer an embryo, we want to make sure it's as optimal as possible. And so we do an evaluation with the uterine cavity, and the fertility world out there is very educated, so I'm probably going to say some things you've already researched and know about. But imaging-wise for the cavity, there's this what's called a 3D sonohystogram, also called the SIS, or an HSG, a hysterosalpingogram. So those are 2 ways, or even the hysteroscopy, which is a outpatient surgical procedure. But the uterine cavity will definitely be evaluated. Lab work. So I mentioned lab work from both sides. Really, a lot of the onus is on the female side of this, because that's where most of the work is being done, I'll be honest. And so the lab work from the female side is really going to get a picture of ovarian function, endocrine profile, and what's called ovarian reserve. And as I go through this process, you'll understand why we get a lot of these labs. I always say that these labs are going to kind of predict and tell me from a prognostic standpoint how IVF may work, but also it's going to help me devise the plan, again, from an individualized standpoint, devise a plan for the IVF protocol. And so just realize that you'll have those evaluations for the blood work in the uterine cavity. And then in addition, the males will have a semen analysis because, as you can imagine, we don't want any surprises when we get to the time of egg retrieval and the male collects and lo and behold, we don't have anything to use. So we don't want any surprises there either. So they will have a semen analysis if they haven't had one already prior to the start of the IVF process. And so those things actually move fairly quickly. Like I said, a lot of our patients have had some of those evaluations before they come to us. But if they haven't, we just simply fill in the gaps and move forward. So that leads me to kind of the what is IVF and how is it done? So I mentioned there are multiple ways of doing IVF. If you remember 3 things in terms of protocols, you'll probably hear these buzzwords as you go through or as you do your research, wherever you do your research. But there are 3 main protocols of how to do IVF. There's what's called the Lupron downregulation, or it's also called long luteal. There's something called the antagonist IVF cycle. And then there's something called the Lupron flare cycle. Those are 3 broad categories of protocols. I will tell you the most common, or the classic traditional one, was the long luteal. Nowadays, we are moving more and more towards the antagonist. So if you hear that more frequently, that is why. And there are a multitude of reasons for that I don't have time to get into. But those are the 3 protocols, long luteal, Lupron flare, and antagonist, that are typically used to get to the egg retrieval itself. And so just realize that those are, which ones we choose are based on that evaluation I just spoke of from a lab standpoint and ovarian reserve. The one thing I will mention at this point is this lab value called an AMH. If you were on last time or if you've seen me before, you know AMH is near and dear to my heart. It's a very good lab value for a woman's egg number, but it also helps me in terms of maybe how they will respond to a certain dosage of medicine, what they may need in terms of the medicines, and how much they may need in terms of how long it may take. And so that's a lab value that I get on every single patient I see. And again, that will help me predict the prognosis of if IVF works, but it also helps me formulate a plan and the protocol based on those 3 generalized protocols I just mentioned. And so I'm going to get into IVF. And again, if you've seen me before, you've heard me say, I think IVF is somewhat 2 phases. All right. So I break it down into the prep phase or the preparation phase, and then I break it down into the stimulation phase, right? So the prep phase is where the eggs in the ovary are in what are called follicles. If you've had ultrasounds, you've probably seen follicles on your ovaries. In the prep phase, we want all those follicles senescent or, quote, quiet. And we do that with a couple of ways. We can actually do birth control pills. And when I say that, patients are like, why in the world am I going to fertility doctor and getting birth control pills? Well, it's very common to use birth control pills to lead into IVF. And we do that because it actually shuts the brain signaling to the ovaries to keep those follicles at bay. And so we can ramp up production of eggs, which I'll get to in a minute. Other ways to do the prep phase is with hormone stimulation. And there are various reasons we do that as well. But I will tell you the vast majority of folks will do the birth control pills for 2 to 3 weeks, again, to keep their ovaries quiet in order to get the stimulation going. So I mentioned the follicles and I mentioned AMH. So in order to try to optimize IVF, it's a numbers game. And so we are trying to optimize it by getting as many healthy, from a health standpoint, healthy eggs as we can. Because in a natural menstrual cycle, there are inherent checks and balances from the pituitary in the brain to the ovaries to really only release 1 egg at a time in a natural cycle. So that's why humans can actually limit the rate of multiples naturally, because women are only ovulating 1 egg at a time, typically. And so in IVF, if I just told you we want as many eggs as possible, we have to kind of shut that process down. And that's where that prep phase comes. So that's where the birth control pills are typically working to kind of quiet that signaling to let us ramp up production. Because the other thing a lot of folks don't realize is in a natural menstrual cycle, which is all we're really accentuating in an IVF cycle, there are actually hundreds of eggs being recruited naturally. That's why from puberty to menopause, which is around 51 in this country, average age, you're going through hundreds of thousands of eggs in that time frame of your life. So you're actually recruiting hundreds, but you're only typically releasing 1 naturally. So in IVF, we're trying to accentuate that recruitment. Now, in no way am I saying we're getting 100 eggs. That's not what I'm saying, because that's not going to happen. I have heard of people getting over 70. That's not me. That's not what I want. But just realize that's the biology and the physiology behind it of how it works. So how do we do that? Well, that takes us to the second phase, which is the stimulation phase. And so I mentioned that the pituitary in the brain controls the functioning of the ovaries and the recruitment of eggs. There are hormones from the pituitary gland called gonadotropins. And gonadotropins, you may have heard of, are called FSH and LH. And we actually have those same exact gonadotropins in injectable medicine form. And so those are the stimulation meds in IVF. And there are a multitude of names for them. You may have heard of Gonal-F, Menopur, Follistim. All these are gonadotropins. And so in that stimulation phase, that's what the patients are taking. And they're injectable medicines just underneath the skin and the abdomen. And so you take them daily. And the starting dose, again, is based on the evaluation we did prior to you starting. So it's really based on the AMH and any other endocrine factors that we have seen, or if you've done some other minor stimulations, we can base it on that as well. So we choose a dose that we think will work for your starting to ramp up, like I said, and optimize the recruitment of the eggs from the ovary. In that stimulation phase, it's usually only about 10 to 14 days. Everybody's different. All ovaries respond differently, but 10 to 14 days is a good ballpark. In that 10 to 14 days, though, we're seeing the patients at least 4 to 5 times. It's usually a morning visit, and those are called monitoring visits. Because if I just told you I choose the dose based on the lab evaluation, I have to know if it's working like we want it to. And so at the monitoring visits, what you can expect is an ultrasound to look at your uterus, your uterine lining called the endometrium, look at your follicles where the eggs are in the ovary, count the follicles, measure the follicles, because we know based on millimeter how well they're, quote, maturing. And then we also get blood work. So we get something called an estradiol level, because we put all that together to say, yes, this dose is correct. You're responding to this dose. We don't need to do anything. Or we say, nope, she's going too slow. Maybe we need to bump up the dosage of the gonadotropins. Or nope, she's going too fast, called hyperstimulating, and we need to try to back down. And so that's why you have those monitoring visits, for us to obviously monitor, but also to hopefully optimize as much as we can, because the goal is to try to get a cohort of eggs to grow together. And that's not always the easiest thing, but that's what we try to do with the prep phase and then the stimulation phase, okay? And so once the stimulation phase is to the point, based on the values of the ultrasound and the lab work I just said, then you'll take what's called a trigger shot. And a trigger shot is just to get ready for the egg retrieval. It kind of gets the eggs, quote, loose. You don't ovulate on your own in IVF, because we don't want that, actually. That would ruin the IVF cycle. It just gets them ready to be retrieved. And so what we do is we say, okay, your ovaries with their follicle number and size are ready to trigger. You take a trigger shot, and 36 hours later, we do the egg retrieval. So basically, let's say you triggered on a Thursday night, you would have a retrieval Saturday morning. That's typically how we do this. The egg retrieval itself, it's probably one of the most daunting things that people read about if they've done some research on Google, Dr. Google or anywhere else. And I get that. I mean, it is an outpatient procedure. Then we have, and as most clinics do, we have our own procedure room with our IVF lab attached. But the egg retrieval is done under IV sedation, and everybody reacts to IV sedation differently. Some clinics have different medicines that they can have, but it's usually what's called a conscious or moderate sedation, where it's not like major surgery. If anyone's had surgery, you're not intubated. You don't have a tube down your throat. It's just an IV that gives medicines through the veins, and you can sometimes take a little nap, but you'll be able to respond to us as well. But again, everybody responds differently. But I will say the egg retrieval itself is usually about 20 to 25 minutes. And we try to get as many eggs as we can. And we do that, again, with a vaginal ultrasound. We have a needle that actually goes through each side of the vaginal wall into each follicle on the ultrasound that we can see, and it aspirates the egg that way. The eggs are immediately sent to the lab to be counted, so to speak. And like I said, after 20, 25 minutes, we're typically done. You go to recovery, you recover for about 45 minutes, and you go home. I tell patients that day, we tell you how many eggs we get. So you'll go home that morning knowing how many eggs we got, typically the final count. If we're not using a donor sperm and we have a male partner, he will collect that morning while you're having your egg retrieval. And that afternoon, what the lab will do, our embryologist will actually take one mature egg and take one normal motile sperm and actually, under the microscope, inject that sperm into the egg. That's called ICSI or ICSI. You've probably seen that as well. That stands for intracytoplasmic sperm injection. The reason we do that is historically that has a higher chance of fertilization. Whereas what's called traditional IVF is where we just place an egg in the dish and place tens of thousands of sperm around it and hope for the best overnight and see if it fertilizes. So ICSI is typically what most clinics will do. I tell you, we probably do that 99.9% of the time, if not more. In terms of the next day, so like I said, you go home in the morning of your egg retrieval, you know how many eggs you got. The very next day, we call you with that fertilization result. So we tell you how well the ICSI worked. Typically, ICSI is around a 75 to 80% or more fertilization rate. Again, everything's a bell curve in life, as it is in medicine, so not everybody's at that 75%, but that's about a ballpark percentage. And so we tell you the next morning, we call you and say, this is how many embryos there are. This is how many eggs fertilized with the sperm. So that's called day one of embryo development, okay? And so what we do from there is we allow the embryos to divide cellularly in the incubators. And if they get to day 5 or day 6, is typically when, quote, something happens. And I'm going to explain what I mean by that. But day 5 or day 6, typically it's called a blastocyst stage embryo, or BLAST for short. Again, if you've done some internet search, you've probably seen the BLAST stage embryo. That just means it's gotten to the day 5 or day 6 stage, and that's usually a fairly competent embryo depending on the grade, because the embryologist gives a subjective grade based on the cellular architecture and blebbing and other things under the microscope. So I said day 5 or day 6 is where we do one of 3 things. Well, one of 2 things really. We can either do what's called a fresh transfer, meaning you've had your retrieval 5 days or 6 days prior, and you come back for an embryo transfer. So we can do the transfer of the embryo into the uterine cavity, and that's called a fresh transfer. More and more folks are moving to what's called a freeze-all cycle, us included, and I'll get to that in a second. But a freeze-all cycle is where, well, it means what it says. We freeze all those embryos. But I said there were 3 options. The third option is that now we can do what's called PGT, which is called pre-implantation genetic testing, and where our embryologists on day 5 or day 6, before they freeze the embryos, can actually biopsy about 3 to 10 cells from the blastocyst, and it's usually hundreds of cells at this point. And so they biopsy it, and those cells are actually shipped off to a specialty lab we have that does our PGT for us, and the embryos stay with us. Once the embryos are biopsied for the PGT, we freeze them. Okay, so that's why I said it's kind of 2 things. It's either fresh transfer or frozen, but amongst the frozen, you can either not biopsy for the PGT or do the PGT. So the question is, well, why PGT? And that's a whole nother topic, but really we know that the gist of it is we know that any couple doing IVF, regardless of why they're doing IVF, will form potential chromosomally abnormal embryos, which either will never make a pregnancy or may cause a miscarriage. And so we're trying to weed that out and try to give the best chances for patients that way with the PGT. It used to be fairly rare doing PGT. I will tell you now, we have probably at least 30 to 40% of our cycles do PGT for a multitude of reasons. One important one is the cost has gone down significantly over the years. Some clinics are probably running 75 to 90% PGT. So it's variable depending on what the patient wants. So the one thing I'll tell you is, or the biggest thing I'll tell you is today is IVF is a numbers game. And you've probably heard me say that if you've seen me. And so if I just told you before that we're trying to get as many eggs as we can, what you have to realize is that does not equate to embryos. So let me explain that. So there's something I call the IVF attrition. And that means at every step of the process that I just went through, there's a dropout for every single couple or patient doing this. And so what I mean by that is we try to get as many eggs as we can. I've gotten 59 out of one person. I've gotten 2. It just is variable among their ovaries, but we try to get as many eggs as we can because not all eggs when they're retrieved are mature. That's just biology. Not all mature eggs fertilize with that ICSI procedure. and not all fertilized embryos go on to make it to that blastocyst stage to try to make a pregnancy. So regardless of egg number, it's probably not going to equate to embryo number. So what are those numbers? So the average yield, if all that testing and the evaluation I mentioned was fairly normal, including that AMH, the average egg yield is about 10 to 20 eggs. Okay, that's average. But at the end of the day, on day 5 or 6, what I always tell folks is if you have 4 to 6 embryos to use, that's a very good number. So really, that's the number I want you to remember is 4 to 6 embryos, because quite honestly, if you have 10 embryos, 11 embryos, what are you going to do with them, right? Because at that point, you may not want 10 or 11 children. So 4 to 6 embryos is probably more manageable. Again, there's a bell curve if we do PGT in terms of how many may be chromosomally normal or abnormal too. So I understand that, and that may further reduce the amount of viable embryos to use if you understand what I'm saying. Going from a frozen embryo, going from a day 5 embryo to knowing which ones are chromosomally normal may also have some attrition at that point as well, some dropout. So just keep that number in mind. The other kind of phrase I always use, and Kristin may talk a little bit more on this too, is it's a roller coaster, and I've used a phrase called forced flexibility. And it's kind of hokey, but it's true. Forced flexibility is on us as the physicians. It's on y'all as the patient, because we are forced to be flexible based on what the ovaries are doing. And then we're forced to be flexible based on what the embryos are doing. It's nearly impossible to estimate and to predict what's going to happen in the lab until we see it happen. And so that's what I mean by that forced flexibility. And I tell that to patients because I want them to be aware and realistic expectations. The other thing that I'll mention before I stop with the IVF process is, I told you there are a multitude of ways to do this, but there's also multiple reasons to do this. And one that's becoming and gaining popularity is for egg freezing. And so egg freezing is obviously where you're not creating embryos with sperm, but you're going through that same exact process of doing the IVF phases I just mentioned, but then you're freezing mature eggs. And that's really becoming more popular as folks are postponing childbearing for whatever reason the case may be. And that's also to try to ensure that chromosome abnormality rate won't increase, and try to kind of freeze time, if you will, because the chromosome abnormality rate will increase as we age. And so egg freezing is becoming more and more popular, but it's also, in unfortunate circumstances, in the face of impending chemotherapy for cancer patients. I've had 2 in the past week do egg freezing because of that reason. So there are a multitude of ways and reasons to do egg freezing, but just realize if you see that, that's another option in IVF. It's just a matter of not fertilizing with sperm. And so the last thing I'll mention is, if I told you that freeze-all cycles are very common now, and like I said, we are doing the majority of our cycles as freeze-all, well, then you have to talk about the frozen embryo transfer cycle. And again, that could be a completely other topic of discussion. I'm not going to go into it at all, all the way, but realize that once we have those frozen embryos, like I said, 4 to 6, they're going to stay frozen for years to be able to use. And so what we do in the frozen cycle is we don't need your ovaries anymore. So you don't have to have another egg retrieval, which is really nice. And we prep the uterine lining for the transfer. And there's, again, another process for that. But just realize that once you have those 4 to 6 embryos, the potential to have multiple transfers and potential for having multiple children is there based on that storage. And so with that, I know I've said a bunch, but I think I'm going to pause. And if you have any burning questions, I guess you can ask now or wait till later. Otherwise, I'll let Kristin take over.
Okay, well, I will give the opportunity if there's a question that's coming up right now that's relatable to what Dr. Likes shared.
I have a question.
Yeah.
Of that 4 to 6, are there percentages out there of successful live births?
Yeah, so that's going to be clinic dependent, obviously. But let's put it this way: if you've done the PGT, and it's what's called a euploid embryo, a chromosomally competent embryo, we will quote about a 60 to 65%. I've seen some clinics go as high as 70% success rate for a positive pregnancy test and then a positive ultrasound.
Okay. Cool. Well, I will thank you, Dr. Likes. I mean, I learned some stuff too, so I appreciate you going into some depth and talking about it. And if you guys have the worksheet, what I plan to talk about today is sort of the 3 most common challenges related to IVF on the emotional side. And clearly, we're all different human beings and we all handle it a little bit differently, but there tends to be common complaints that come up that I see all the time. And so I just want to talk about what those 3 main things are. There's definitely more, but for sake of time, we're going to talk about 3. And then I'm going to share sort of a way to help you if that's a challenge that you're dealing with right now. And really all of this doesn't matter what stage of the infertility or IVF cycle you're in. So the 3 most common challenges, and I will tell you they are not necessarily that you're giving yourself shots. I think a lot of people are scared for the needles and the shots at first, but I think for any of you who are on who've already done a round of IVF, it's like after 3 days, you're like a pro and you're mixing the Menopur and you're like, oh my God, I've got this. So that is an easy hurdle that people tend to get over. But the real big challenges are all of the waiting, the lack of control on this big goal that you want so bad, like every fiber in your body, and there's only so much you can do. And then just this overwhelming sense of feeling alone or feeling left behind, or feeling like you don't fit in with your friend groups and, the people in your world. And I think those are the 3 biggest that I'm going to talk about today. So challenge number 1 is all about waiting. And the reason why I think this is such a big challenge is that you are waiting at every stage. You are waiting for your consult. You are waiting then to get the calendar, and you're waiting for your meds to arrive, and you're waiting for your cycle to start to call them up and say, it started, okay, let's do this. And then you're waiting for the first monitoring appointment and all those steps. And like what Dr. Like said, the egg retrieval, and how many did you get? And then you have to wait for the day 1 report and the day 3 report and the day 5 report. There's waiting at every stage. And if you were here last month, I also talked about how just getting the positive pregnancy does not stop. Like you're still waiting for the next stage and the next step. And so waiting is a legit thing. And then we had the, pandemic pause. Y'all in the South and in South Carolina, luckily practices are opening up here. That's not the case for all of our infertility sisters across the world. In the US, a lot of places are still being closed and still not open. So waiting is something we have to be very familiar with. The thing to deal with waiting is you have to keep your thoughts and your energy focused on what you can control. You have to focus on the present moment and the next step, and that's it. We get so ahead of ourselves when we think of, what about this and what about this and what about this? You have to focus on today and the next shot or your next scheduled appointment, and keep it focused on today and in the moment, because otherwise you are literally going to be wishing your life away. And our 20s and 30s are really good years and times, and you don't want to be wishing your life away. Life is short already. If you're waiting for a hurdle to cross all the time, you're going to be unhappy. It's going to cut you, like it's going to crush you emotionally. So the best thing is to focus on what you can control, to be present in the moment, and to literally think about just the next step or today. Challenge number 2 is a lack of control. And I think women in general like to be in control. We like to know what's going on. We like to plan. And then, you always think that you're going to get married and then you're going to wait a couple of years and then you're going to try and get pregnant and boom, it's going to happen. It just, for us, it doesn't happen like that. And so we don't have control over that. We don't have control sometimes with the clinic and when they can fit us in or not. We don't have control of sometimes of our appointments. There's a lot that we're lacking control wise. And that is what makes people feel uncertain. And that is what makes people feel anxious and nervous, is not having any control. So you can actually get a sense of calm and a sense of power back when you control just 5% of your world. When you take back 5% of control in your life, there are studies that just says all you have to do is take back 5% of your life and you will feel a difference. You will feel an improvement and you will notice the power that you have over your day and over your goals and over everything you're doing. So you just need to improve 5%. If you think of like, my whole life is out of control, I can't fix it all. No, you can't control it all. You can't fix it all. 5% is all you have to do. So there's a lot of different ways to do it. I'm going to speak quickly about these ideas. These are the kinds of things I go deep in with my clients when we're working one-on-one. I also have my own Facebook group. And so I do lives like this once a week, and I'll talk a little bit deeper on some of these topics. But I'm going to tell you like 6 or 7 things that you can do. And they're things that are easy, free, you can do right now. And these are small ways to get back 5% control of your life so you can feel better. One of them is to educate yourself. The fact that you guys are here, like, check that off, right? Awesome. Rock on. Another resource that I love is Fertility IQ. I don't know if you guys have been there. It's awesome. They have like free trainings. They do videos all the time. It is a couple that's going through IVF that's doing it. They also are really good at reviewing doctors, and you can review your own doctor. There's really good questions. They also do grants where they'll give $10,000 grants to people. If you've reviewed your doctor, they will give away 10,000 grants, $10,000 grants like a couple times a year. And like, I have done a review of my doctors, and if I win, I can give it to a friend, which is kind of cool. So do a review. It helps other women find good doctors. It also submits you to win a grant. But Fertility IQ is a really good resource for education. Resolve.org is another one. So those are ways. Don't go down the Google rabbit hole, Dr. Google, like, don't do it. Use some sources that are much better, whether it's your fertility clinic's actual website or Fertility IQ or Resolve.org or something like that. Schedule, plan, count on doing one fun activity a day. Whether that's with your partner or your spouse, whether that's having silly dance parties, listening to music, watching a show you love, try and do one thing that's fun every day. And the best thing for me is I literally on my calendar, I put like a smiley face on the days that I do fun things. And if you're tracking everything else in your cycle in your life, there's a calendar in your world, like keep track of it and have fun. It doesn't have to cost anything. It doesn't have to be big. With all of us being socially distant, it doesn't mean trips, but do something fun every day. The other thing that you can do is something kind for other people. One, it helps them, but it also helps you. There's so many studies talking about doing altruistic tasks. Really, it helps you almost more than it helps the person who's receiving it. But think about that kindness that you're putting out in that world, in the world. And I think the world just needs more kindness anyhow. It could be writing a letter to a friend, bringing over baked goods. I literally have hydrangea plants that are blooming like crazy, and I trim them, I cut some off, and I deliver them to my neighbors. So it's like little things like that. Yeah, they were probably happy to get it, but like I felt even better doing that. So silly. But it helps. Routines are another big thing. And I talk about routines day in and day out. So it's kind of like how Dr. Likes was talking a few things over and over again about how, IVF is very individualized. Like I'm going to say things over and over and over again. Routines and habits is one of them. Having a routine like in the morning or at night, or even at the end of your work day. Like if you're working from home right now, having a routine where you actually go on a walk at the end of the day. Like that's when you're shutting down the computer and you're done being the working person and you're now, the spouse and your work day is done. Having routines in the morning on getting up and listening to music or working out or reading a book or reading the Bible. Routines really matter. It gives you back control. It's something that you can do. You can do every day. Whether that's taking your vitamins and your supplements every day and saying a prayer with them or saying a mantra and affirmation, like saying like, I am so thankful I have this opportunity to take these to make my body better or to prepare me for my IVF cycle. that could be a routine that you implement and do every day, which will set your day off on a good way. Habits, I talk about those all the time. The reason why habits matter is, and routines too, when you do them and they become normal habits and routines, and they're things you don't think about, you do them, they're just something you never cancel on. One, you are making promises to yourself day in and day out. And that is something that's really good for your heart and your emotions, is making promises to yourself and delivering on your needs. The other thing is there's kind of like an exhaustion that can happen at the end of the day, like decision fatigue. And if you're thinking about stuff all day long, when something comes at you that's out of the normal, like infertility is a roller coaster ride. It is not a straight line from the first appointment. Like all of these things, all these steps that Dr. Likes talked about, it's not just boom, 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 boom. There's so many opportunities for bumps in the road and pauses and things to not necessarily go as planned or right. And so if you have spent a lot of your day doing routines that are easy, like you have the same thing for breakfast all the time, or you're always unloading the dishwasher before you go off to work. So like you come home and like the sink is clean, like all of those things they help you at the end of the day. So when something does go wrong, it doesn't like throw you off. You don't make the easy choice in those moments because you're not exhausted. Also, habits help when they're healthy or they're good habits. One, because they help you physically. IVF is a mind, body, emotional, spirit, all of the above thing. I think it's like the whole package. And that way you're taking care of the whole. But it also, when you're having bad days, having those habits, those things that you don't quit on and you always do, they're the things that are going to get you out of bed. They're going to get you out of the funk. Like I'm all happy-go-lucky, but I also cry my face off when it's appropriate. I have my moment and I can move on from it. And I know that when you're in the depths of IVF, it is possible to stay there, to feel like you're not making progress, to feel like you are being buried or the cloud is over you and it's not moving. Like I know that feeling, I've been there. But when you have habits to rely on that take care of your body and literally like the physical part of your body that feels better when you work out and you exercise and when you eat the right foods, like it all matters and all is a step in the right direction. And then the other thing that you can do to take back control is to take the time to focus on your partner. You guys started as like a unit of the two of you, and so many relationships are challenged with infertility. It's just one other level. And it's so important to remember, like, that's the foundation of your family and you want to add a child to that, but like you guys need to be strong too. And sometimes infertility just becomes all consuming and that's all you talk about with your spouse or your partner. And so if you take the time now to really proactively not date your partner, but like have fun and like be involved and be into each other, because guess what? When you have that baby, you're going to be exhausted and you're going to have less time to do all that stuff. Because I really believe if you want it, it's going to work. It's going to happen. You're going to be a mother. It's just taking way longer than you think. And I know that sucks, but it's going to happen. And so you've got to keep the foundation. Good habits for you and your body are good for when you're pregnant too. And they're great for when you're a new mom and you're going through the 4th trimester. And they're great when you have a child who's watching you and learning from you. So start now. Like Dr. Likes talked about the prep, like you're in the prep of like all of this. So do that. So those are all the ways you can take back control and feel better. So the third challenge is feeling alone. And I hate it because I know, and I'm an extrovert. I love being around people. This social isolation is killing me. But you are actually not alone. There are so many people. And I think the waiting rooms are a little bit different now because of the telehealth and all that's happening and the limitations. But, the waiting room dance of avoiding eye contact with people to not talk, like those women in that room at the same time as you are going through the same thing. It's okay if you're not going to talk to them at that moment because you're all hormonal, and I understand. But there are a lot of resources and tools out there to help you, because when we're going through something challenging and hard, one way to make it better is actually to have a shared experience. Like your dopamine levels improve when you are going through a shared experience with somebody else, when you guys are doing something together. And so that's why support groups matter. That's why they're so successful. That's why they're for everything, right? Like all these issues and conditions have support groups. Infertility is not one of them. We just go through infertility under like this cloak of secrecy. So it sometimes can be really hard. Also in the South, everybody knows everybody. And sometimes you just don't want people to know your stuff. But so there are options. So I'm going to go through a couple of the options. But the key is that each one of us needs different emotional support. We need different support to help us not feel alone. I had amazing friends who were so supportive. They remembered every appointment. They checked in. They sent me texts. But they were popping out their babies left and right. And they just still didn't get it. Like they were doing everything they could and just, it still wasn't enough. And I just needed a little more. And so when you, when you meet people who like get it, right? It's like, hey, best friend, like you've been through it, you understand. And so I just hope that you can find it in a level that's comfortable for you because there's so many options. So deep breath. Okay. In person for finding people that are kind of local, for local support, resolve.org, like I mentioned, they do support groups all over the United States. You have to go to their website, like put in your zip code, and they will then tell you if there's a support group in your area. Churches will also do it. So if you have like a children's minister or something like that, I would reach out to your church to see, or a women's group to find out what kind of support group they have. A lot of infertility practices might offer some support groups for their patients. So those are sort of your local in-person support options. Workshops like this, there's a lot of people doing more stuff online because, pandemic, stay safe. So keep doing this. I mean, the fact that you guys are here is awesome. It honestly means that you clearly are looking for something. And keep your eyes open for more workshops like this. I leaned on Instagram and I made a secondary Instagram account that was private. And that was a good outlet for me to journal what I was going through. But you don't have to be public to get support, but you can use social media. So you can do Instagram. You can just follow also different Instagram accounts. And it's funny because now that account is what I use from this coaching business. There's also Facebook groups galore. Like there's one, it's like IVF support group has like 28,000 people. So y'all, you're not alone. I know you feel it. But you're not alone. Because 1 in 8 couples, like 1 in 8, like out of this group, like just 1 in 8, that's so many people that are going through it. We just never know it. And a lot of times what will happen is you're private about it. And then once you get successful, then you like tell people, oh yeah, by the way, we like went through IVF. And then it's like, you have 2 friends are like, oh, me too. Like, why didn't we talk about this? So those are all the different supports. The other thing is that you can go and talk with a therapist and you can work with a coach, someone like me. There's options out there. The therapist and the coach is more individualized one-on-one. So those are all those options. I mentioned before, I do have my own Facebook group. It's called the IVF Sisterhood. And I do live things like this once a week. And it's something small that's growing. Love to have you if you want to be in it. But I want you to walk away tonight knowing that there is a way to get the support that you need. So don't be shy about looking for it. So that's what I was going to talk about today. I'm done crying. I guess now it's time to open it for questions for either Dr. Likes or myself. So you can unmute yourself if you want to ask a question. And I don't know if there's lots of questions or not, but go. Does anybody have a question? Or Dr. Likes, do you have anything to say after me while people think about it or unmute themselves?
No, I appreciate you saying what you said. I guess I would just kind of get feedback in terms of, does it all make sense? Again, I know some familiar faces out there, but does it make sense in terms of what we all said? And that's kind of where the Q&A comes from. So if you have questions, definitely let's get some clarification if it wasn't clear.
I have a quick question about egg quality.
Yeah.
Yeah. a lot of people that I speak to and talk to, they talk about this book. It's all about the egg, and they talk about nutrition and supplements and all that. And then there's a lot of scientists out there that are debunking all that, and they just said your eggs are what they are. What are your thoughts?
Yeah. Now I know who I'm talking to right now too. So no, but it's very difficult to assess quality. There's not one blood work, one blood test, one ultrasound, anything I can do or any doctor can do to give an egg quality aspect, and that's extremely difficult. And oftentimes, like I said, in terms of the forced flexibility, we don't know until we see it in the lab. And even then, we still really don't know. So for instance, if we have 16 eggs that are ICSI, but only 5 fertilized, was that because it was the egg quality or was it because of the sperm quality? I don't know. And it's very difficult to pinpoint. I will say, and to your point, and Kristin mentioned this, we have patients on a number of supplements that we think can help. Not only egg, but also sperm quality. And so some of those are the coenzyme Q10 and vitamin C, vitamin E, those sorts of things. But again, or even some DHEAS or DHEA, some studies will show that evidence goes up and down, like you said. But even then, it's hard to pinpoint which one, but we don't think it is harmful by any stretch, and we do that because we think it can help from a mitochondrial boost and antioxidant kind of thing. Obviously, we ask patients about smoking and drinking and obesity, those sorts of things, because we do know that can affect egg quality in terms of to what degree. We still can't tell that, but we know that it has an effect. And so obviously we're going to say from a, like Kristin said, habit standpoint, let's trim some of those habits back if possible. But I wouldn't say it, I'm not debunking it. I would just say it's very difficult to get your mind around if you take this one supplement or eat this one vegetable that your egg quality is going to get better. I know that was a Switzerland kind of answer, but I don't think there is any right answer, quite honestly.
No, that was good. Thank you.
Sure.
Well, in my perspective as the emotional side of it, sometimes it's the placebo effect. If you're taking a vitamin that costs $20 and it might make an improvement, why not? Y'all, the amount of money that goes in, why not? That is a simple, easy, that it doesn't have the side effects. Now, don't go crazy, but if your doctor's saying it's okay to take CoQ10, my thought is, why not? And I'm going to, again, when I take it, I'm going to be like, this is helping me. This is getting me one step closer. Yeah. And that can make, I don't think that if you believe, you're more likely to be successful. I don't think that. But I think that when you believe, it makes every step and every choice and every day easier.
Another thing we oftentimes will use, depending again on the lab work and evaluation, is metformin or some sort of an inositol, because we do think that can help with egg quality as well. So if you have a physician that's put you on that from a fertility standpoint, that's probably why, in addition to other things.
Good question.
I have a question.
Hey.
Hi. So I was curious, what makes the determination as to whether or not, when you're going through an IVF cycle or an FET, as to whether or not you're put on Femara and Lupron versus being just, I've always done Femara and Lupron and now I'm not. And so I'm kind of curious what that distinguishing factor is and which is more successful based on what.
Yeah. So are you talking about a fresh cycle or frozen?
I guess both. Frozen. Or both, yeah. Just kind of curious what the
yeah. So Lupron I'll take the fresh part first. So Lupron in a fresh cycle it's used in a couple of possible ways. One is if there's any suspicion of endometriosis, we may suppress that with what's called a prolonged depot Lupron or just longer Lupron acting medicine. That's not as frequent anymore. But Lupron in fresh is also used in that long luteal protocol I mentioned. That's kind of the gold standard. That's how IVF started. And it just, all that does is the short daily shots of Lupron will just keep your pituitary suppressed so we can take control. So that's Lupron in a fresh. Femara in a fresh, really the only time I've used that is in like breast cancer patients who are estrogen receptor positive, and we want to keep their estrogens a little bit low. Yeah, we use Femera in their fresh cycles then, but otherwise we don't typically use Femera in fresh anymore. So frozen is another ball of wax. So frozen cycles, same thing in terms of Lupron, but also same things in terms of Femera. Sometimes we put patients on that if we suspect a high incidence or high prevalence in their pelvis of endometriosis as well. I will tell you, we just had a Journal Club meeting today. As was just discussed in terms of not debunking, but the evidence, it kind of, you've probably heard me say it's like a sine wave in terms of yeah, it's really popular. And then, well, some studies come out, well, I don't know if it's really that popular. There are a number of folks, me included, who will use the Depo, Lupron, and Femera in preparation for a frozen just to try to get the uterine receptivity a little bit better if we think endometriosis or other factors are playing a role. But again, that's sometimes going to the wayside. But also to your point, Lupron has been used in frozens, again, for the prep to get the ovaries quiet. Because again, remember I said in the FETs, you don't need the ovaries. And so we just keep them quiet, and Lupron's another way to do that. But we've also learned now that birth control pills and then leading into estrogen progesterone supplementation for the frozens is just as, if not as more effective than doing Lupron in terms of cost, more shots, and more time.
Okay. So it's not so much, it's more of an individualized if there's a depending on the underlying issue.
Absolutely.
Okay. I understand. Thanks.
Sure.
Hey, Dr. Likes, there's a question in the comments that somebody wrote. What's the success rate of ICSI using sperm that has a triple defect?
Yeah, so I'm assuming when you say triple defect, you, well, semen analysis, do you mean it's called oligoacinoteratospermia, low numbers, low motility, and morphology is low. Yes, okay, thank you. So with that, I don't mean to sound hokey, but the beauty of IVF with ICSI is that, you know, in a typical sample of sperm, there's millions of sperm. But even in an IVF, if there's just hundreds of thousands or even less than that, they only need one per egg. And so the chance of finding a fairly normal motile sperm per egg is fairly high. I trust our embryologists implicitly because they are exceedingly good. This is an N of one, but I've had a patient who was actually a soldier who was paralyzed, and he had to have testicular biopsy. And we used frozen biopsy specimen. They found, I think, 6 sperm, and they have a child from that. So, I mean, if you can find one that can fertilize the egg, that's good. So the triple defect and with IUIs, inseminations, or trying naturally, yes, that's going to have a significant impact in terms of decreasing fertility. But if we can get one fairly looking normal sperm per egg, that's a good thing in IVF. And I would still say, sorry, real quick, I'd still say if you have that, I think I quoted about a 75% fertilization rate with ICSI. If all goes well, I would still hold to that.
Okay, somebody was asking a question before. You can come. Was it Adeline? Yeah. Okay.
Yeah. I just wanted to. I'm sorry to have the camera. My hair is.
That's fine.
But so I'm with about. It's only 6 people in my office right now, and 3 of them tested positive for coronavirus.
Wow.
I have no symptoms. I'm on day 5 of stims. Yeah. And I don't know if you've come across that. What's the protocol? My doctor keeps telling me, well, we'll wait until you get your test result back. But, of course, the waiting game kills me because everything is about waiting. I don't know if it's like a flu protocol, like if somebody gets the flu, like I don't know what happens.
That's a great question in the time we're living in, and it's ironic because we literally just found out today that we have a patient not in the office but who's tested positive, and she has to postpone because she hasn't started yet. But I would first things first, we have to go through this discussion with patients nowadays that there is a big unknown with COVID and pregnancy because we just don't have the data, because we don't have a lot of early pregnancy patients that have COVID. And so we don't know if it affects pregnancy itself sorry, that's my dog. If it affects the pregnancy itself, if it affects the pregnant mom or affects the developing baby in the first trimester, we simply don't know. So we have to say that. I will say, however, that it does not, does not look like it's a Zika kind of thing, because you remember the big Zika virus was a big scare. I can't tell you that 100%, but it's not looking like that. It's also not looking like H1N1, probably, gosh, what was that, 16 years ago, where, not that long, 13 years ago, where it was a predominantly bad in pregnant women in terms of a lung manifestation and hospitalization. So we haven't seen that. So it's a matter of unknown, and we're learning bit by bit as time goes by, early pregnancies. Now, that being said, I will tell you different centers will have different protocols in terms of what to do if you've already started STEM. Obviously, social distancing, wearing a mask, good practice of hygiene is going to be imperative. The other question is, would you ask to have antibody testing? Obviously, in the world we're living in, antibody testing is a question mark as well, whether or not that provides complete immunity. But I would think if you had antibody testing and you were positive, I would feel pretty good about it, meaning you may have had it and didn't know, or you have antibodies to it now. That may be certainly one thing I would ask. The question is going to be, do you stop? Because then and I know that's very difficult, but should you get sick and then, or you have a procedure, then you get sick, it's going to be not only, I'll be quite frank, it's not going to be you, it's going to be the folks taking care of you, and you're going to be sedated with your egg retrieval, and you may have a cough at that time, and so forth and so on. So I would ask them what their protocol is, and then I would ask them also about antibody testing.
Okay. Yeah, I mean, I'm okay wearing a mask, and I feel fine, and I'm a big germaphobe, and I have my office away from everybody, and I have essential oils burning all the time. But,
yeah.
trying everything and anything to,
yeah.
And I'm not going to go to the office anymore after the test came back today, but I just don't know. Yeah. I mean, should I stop using the pens that are worth like $1,000 and, start again? I don't know.
Does your clinic know this yet?
Yeah, I called them and they said, well, just let us know. I did the test yesterday, the COVID test yesterday on the drive-thru. Yeah, okay. So they'll let me know, but they said, well, we'll let you know in possibly 5 to 7 days, and my retrieval scheduled tentatively for next Wednesday.
Sure, yeah.
So, I don't know.
That's tough. I mean, it's going to be completely what you feel comfortable with. Mm-hmm. 30% at least are asymptomatic. I think that's what the CDC just came out and said this week. That's a big portion of us that may have had it and didn't even know. So did you do a rapid test by chance, or because sometimes they can get it back a lot quicker than 4 to 5 days?
They said it could be less, but they haven't told me.
Okay. I would, if you're feeling well and you feel okay proceeding, I would say wait for that test or ask for the antibody test.
Yeah. Okay. Thank you.
Sure. I will say also to that point, some centers, I have a friend in New York, obviously the Epicenter, he did a webinar, what was about 3 weeks ago, I guess. And he was, I think, going to employ testing on every potential cycle they're doing before and then right before they start. So there's so many different protocols out there, I'll tell you.
I was kind of even hoping that the clinic would say they had one, but they didn't mention it. So. Yeah. Also, I did go to an acupuncturist, and he wanted to up my my vitamin D. I know we talked about that a little bit, but he wanted to up my vitamin D dosage to like 10,000.
Yeah.
That sounded insane. The nurse said, yeah, it's fine. But then another nurse said, I probably wouldn't do it. And I never got to talk to the doctor. So I don't know if that sounds crazy.
How often did they say take it?
He said 15 days and then 5,000 after that.
Oh, yeah. I mean, I think that's okay. It's just front end loading. There is a lot of studies about vitamin D and fertility. So I don't think you're going to overdo it with that. Could you just do 2,000 to 5,000 a day and be okay? Yeah, probably.
Okay. Yeah, he said that and then add some K2.
Some K2 or vitamin K?
he says K2, some vitamin K2 that would help I don't know. I'm already taking so many meds. I didn't want to add
Yeah,
any.
I know. I'm not familiar with K2. I apologize.
Okay. I wasn't either. So.
Okay.
It helps with the absorption of vitamin D.
There you go.
Yay.
Why is it 2? I know vitamin K does help stuff, but what's 2?
I'm not quite sure what the 2 is. It's a completely different K vitamin.
Okay. All right. Fair enough.
All right. Are there any other questions? We're here for you guys. So let us know what you need. Did it all make sense, what we were talking about for the 3 of you on video? You can nod. Okay.
All right, y'all.
Okay. Well, yay.
I do have one question, if you don't mind.
Yeah, go ahead.
So I'm in a bit of a unique situation. I'm actually not married yet. I'm getting married in 2 months, and my fiance has had cancer twice before, and he had a stem cell transplant. So before he had that done, he did have sperm samples taken, obviously, just in case he was infertile afterwards. So we have tries saved up, but I also have PCOS. So we're kind of like, we've known since like well before we even got engaged that it was likely that we would probably have to go straight to IVF for the best chance of success, since we have limited tries and I have PCOS. We don't really want to play around with that too much. So we were just pretty much going to go straight to IVF. So it'll be a few years before we have kids, I think. I'm only 23 and so is he. So obviously we have a bit of time. But I was wondering, is there anything that I can be doing or he can be doing like now, like physically or medically or even emotionally, to kind of like prep for that? Because I mean, I feel like, you know, even though it is a big thing, I feel I'm glad that I know that I have PCOS and we know that he has that issue. So now we can have a little bit of time to, like, if there's anything we can do to prep ourselves, if there's any possible way to prep for that. I don't know if there is, but anything we can do to make it easier for ourselves, I feel like that would just be a really good thing to do, if you had any insight on that.
Yeah, I mean, I think Kristin can talk to some of these as well, but from a medical standpoint, I mean, a couple of things. One, yes, y'all are both very young, and if you're not ready for children, totally understand that. If you were, say, 30, I would say, well, do you want to go ahead and do the IVF, freeze the embryos, and just use them later? I mean, that's still an option for you. I mean, that's kind of drastic at 23 maybe, but it's still a very valid option. If you're not ready, you go ahead and have them and be done with it, and come back for the frozen when you're ready. Another thing in terms of just a lifestyle is, you know, I mentioned the metformin, I mentioned Ovasitol. Not necessarily do you have to go on that. If your AMH level, and I don't know what they based your PCOS diagnosis on, but if your AMH level is really good or really high, really the biggest thing is if you're not having regular cycles, menstrual cycles, that's probably the biggest health that I would focus on, health issue I'd focus on is to keeping that part healthy. And there's a number of ways.
I do have very regular menstrual cycles, which
Okay, that's good.
I'm very happy about that. I'm trying to keep it there. I was on for years and got off. It made me feel terrible, but I decided if I originally got on it in like high school for acne, and then I just decided, well, I don't need it right now. I'm
Sure.
not. So I just got off it, and they based my PCOS diagnosis on hormonal levels. Like I had too high testosterone, and also I had other symptoms, but I have a very regular menstrual cycle. So I want to keep that there, and I want to, just prep myself as much as possible.
I mean, if you've had that evaluation, you have regular cycles, it sounds like from that aspect, you can either do nothing in terms of your cycles, or you could go back on pills and just keep it at bay, because you may see the testosterone levels creep back up. I mean, PCOS is a continuum, and metformin, birth control pills, other supplements can help that. But again, if you're not having any issues, I would honestly, everything in moderation, diet and exercise, and keep yourself healthy.
Yeah. Okay.
Again, the nutritionists on the board may have other thoughts on that, but there you go. So that's what I would say.
Is PCOS genetic?
It's probably one of those multifactorial that we just can't pinpoint a necessarily gene for it. It's probably like anything else that, quote, runs in the family. That, you know, I've been taking a statin for cholesterol since I was 25 years old. I don't know the gene for it, but it's multifactorial. So it probably has something to do with familial issues, yes.
She's my cousin, so
Yeah, of course, yeah. Yes.
Gotcha.
we
You
both.
tried to trick me on that, Kristin. That was good.
I did, yeah. Sorry. Sneaky.
I didn't fall for it. Okay.
I have a quick question real quick.
Yeah.
For the AMH, what did you say like the normal level was for that?
Yeah, good question. So I usually say someone in their 20s and up to mid 30s is about a 1.2 to 3.5, 1.2 to 4.
Okay.
The AMH level of 1 is about where a 40-year-old female should be.
Okay.
So that's why I say I use that a lot in terms of prognosis for IVF, because as I mentioned, it's an egg number issue a lot of times too.
Yeah.
So if we're starting with a lower AMH, I may be a little bit more aggressive with the protocol. The other thing I oftentimes will tell folks is AMH, a low AMH in a younger reproductive age woman. So like I've had a 29-year-old with an AMH of 0.7, let's say. A low AMH in a younger reproductive age woman doesn't portend as bad of a prognosis potentially as a younger AMH in an older reproductive age woman. Now, I'm older than everyone on this board, so I can say that. But older reproductive age is going to be, 37, 38, 39. And if you read the books. I know. I hate to say that. But that's what I mean by the AMH level.
Okay.
Dr. Light,
Yes.
have you seen any correlation between secondary infertility and having a previous C-section?
The short answer to that would be yes, but the question of why is there. Now, some people will say, could it be the C-section, could it be the C-section scar, could it be something with the myometrium of the uterus? It's probably a combination of those. But the medicines that you do to prep a lot of times for frozens can overcome that. But again, I say this, I'm a big picture kind of guy, and there are a multitude of patients who have had 1 or 2 C-sections and still get pregnant with fertility measures. And so I don't think it's a black and white 100% that if you've had a C-section, it's going to say, no, you can't get pregnant again. It's just a matter of doing that proper evaluation, seeing is there anything else that could be corrected from the uterine standpoint. I really don't think it necessarily obviously has anything to do with an ovary standpoint, unless they've had a vascular injury at the time of C-section and compromised your ovaries. But other than that, I would say I have plenty of people who've had a C-section and have secondary infertility, but then go on to have another child.
There's a question, Dr. Likes, in the comments too.
So what is the success rate on egg fertilization when using sperm from a testicular biopsy? Doing the biopsy due to CF, male factor. FSH levels were just fine. No known for female fertility issues, just had SI associated with what everything looked perfect. So, all right, lots in that. Again, so that goes back to that question I had before with the triple defect. If they are able to get viable sperm from a biopsy, because there's 2 ways to try to get viable sperm. It's either what's called an epididymal aspirate, which is an aspiration from the epididymis, which is the top portion of the testicle, or what you're describing as a testicular biopsy, actually wedging a piece of the testicle out and looking for the sperm there. If they can find mature sperm, I think and they look normal, I think you would be on the level of what I've mentioned before if they're able to do the ICSI procedure. Now, I will say, and this probably has been done, sure, that if your partner has cystic fibrosis, it is highly recommended that you get your carrier screening to see if you're cystic fibrosis. I don't know your race, but in Caucasians, it's 1 in 25 we're carriers. And so if you have not been tested, I would highly recommend you get tested because if you're positive, you would have a 25% chance of having a child with cystic fibrosis. And then that's where the genetic screening of embryos could also come in. So you see how this can, there you go. Okay, good. You're cleared. Absolutely.
Okay, well, Dr. Likes, looking at the time, it's almost 8:45. So do you need, and Do you need to go? One more question?
I'm
How you feeling?
fine with- she's kicking me out because she's going to do the support group without me, which is fine. It's good. I'm the only. I get it. I'm just kidding, Kristin.
No, I want to be sensitive to your time. And so I feel like we could ask questions all night long too. So yeah, I feel like nobody's jumping up. So this might be a good natural.
All right. Thank y'all.
Thank you.
Take care.